Sir, can I start?
Yes,
Okay.
please.
Good evening, everybody. A warm greeting from SAMS and the Society of Anesthesiologists, Nanded. Respected President SAM, Dr. Avinash Bhosle sir, Vice President Dr. Vikas Karne sir, President-elect Dr. Rajesh Dagadpalli sir, Treasurer Dr. Sachin Chandolkar, Editor SAMS Newsletter Dr. Shilpa Tivaskar, today's esteemed guest from National ISA, Honorable Respected President National Dr. Naveen Malhotra, Vice President National Dr. C. Radhakrishnan Rao, President-elect National Dr. A.L. Meenakshi Sundaram, Honorary Secretary National Dr. Rajiv Gupta Sir, Honorary Treasurer Dr. Sunil Kumar Sethi, Editor-in-Chief Dr. Madhuri Kurdi, GC Member National Dr. Indrani Hemant Kumar, Dr. Cham Sir, Dr. Manjusha Shah, Dr. Parul Jinder, the MMC Observer for today's webinar, Dr. Sanjay Patange from Nanded, all past office bearers, SAMS, advisory members of SAMS, GC members of SAMS, President and Secretary of various city branches, and dear ISCs. I welcome you all in today's SAMS curriculum, the webinar on anesthesia guidelines from paper to practice, and again, the felicitation of newly installed ISA national body. Next, Ganesh. Ganesh, next slide. Now, taking the blessings from Ma Saraswati, we want to begin. Now invite our President, Dr. Avinash Bhosle sir, to deliver his welcome address. Next slide.
Good evening, everyone, and welcome to today's Science Colloquium on this magical Christmas Eve. I welcome all the national dignitaries to this webinar. Sheetal have already taken the names, so I will not repeat. I welcome all to this webinar. The lights are twinkling and carols are filling the air, and we gather to share knowledge in the spirit of the season. Our ISA shine like a Christmas tree. Its branches, state branches, zonal branches, and at the top the national branches, all glowing together. Christmas is a time of celebration, and we are honoring the felicitation of our newly elected national office bearers, a moment that reflects our shared love and unity. Let us celebrate the new office bearer who have just taken the charge and working tirelessly for the betterment of ISA. Thank you all for joining and making this evening truly special. Wishing you all a happy Christmas ahead.
Thank you,
Thank you.
sir. Now it's time to
Yes.
felicitate all our national honors. Now I request President sir to introduce our President, Dr. Naveen Malhotra sir. Next slide. Ganesh.
Yes. I congratulate Dr. Naveen Malhotra, sir, as a president, ISA National Headquarters.
Next slide.
Thank you. Actually, sir does not require any introduction. Uh, he is known to all of us. He is MBBS, MD, Anesthesiology, DNB, FIA, PM. He is Senior Professor and Director and Pain Management Center at Rohtak, Haryana, India. His former head Pain Management Center. I will not read all this biodata. You are just you know Malhotra sir. Uh, sir, when sir was ISA secretary, fortunately, I was also honorary secretary of Maharashtra State. So I know him very well. He is a truly visionary leader. He had done so many activities in his tenure. Various cells he formed as fit anesthesiology, cultural, and so many activity. Many things he had started during his secretary tenure. There were a lot of activities. Most important, I remember he had ISA flame across the city and state branches of the ISA and spreading the message. The message was very important. Light the spark of ISA in our hearts, light the spark of ISA in our hearts, and celebrate the pride of being ISIan. He first used this word ISIan, and that spark uh, mm, in May, that spark was in many hearts of the ISIan. So he was a very motivated, and he motivated so many people in our state also. I have seen him. Thank you very much, sir, for joining me, and I wish you all the best for your tenure as a president of ISA. Thank you very much, sir.
Thank you, sir. Now it's time to felicitate our Vice President National, Dr. C. Radhakrishnan Rao. So I request Dr. Vikas Karne sir to introduce.
Good evening to all, and it's my pleasure to congratulate Dr. C. Radhakrishna Rao, the second year as Vice President of ISA National, and it's a pleasure to introduce him. Next slide, please. Uh, Sir is Vice President now of ISA National. He is currently working as Chief Anesthesiologist at Gandhi Hospital in Secunderabad, and he is a former professor and head Department of Anesthesia at Gandhi Medical College, with more than 38 years of teaching experience in various government and private medical colleges. He was ISA National GC member between 2014 to 17, and he also served as a president and vice president of ISA Hyderabad City during 2002 to 3 and 3 to 4 respectively. His various scientific papers were accepted for World Congress of Anesthesia, and he also received Best Teacher Award in 2005 at Gandhi Medical College. So welcome to you, sir, and congratulations again. And we all, on behalf of members of Society of Anesthesiologists Maharashtra State and all office bearers, wish you very all the best for your tenure. Over to you, Sheetal ma'am.
Hello, thank you, sir. Now it's time to felicitate President-elect Dr. A.L. Meenakshi Sundaram, sir. It's my honor, sir. First of all, I will congratulate you for becoming the President-elect ISA National. Next slide, please. It's my honor to introduce the President-elect National, Dr. A.L. Meenakshi Sundaram, sir. He has passed MD Anesthesia and at present he is a professor of anesthesiology and Dean Government Medical College, Perambul, Tamil Nadu. He is a President-elect ISA National, Vice President ISA National 2016, GC member ISA National 2010 to 2012. He is President ISA Tamil Nadu State 2011-12. He is the Secretary of ISA Tamil Nadu. He was then President ISA Tanjore City Branch and Secretary ISA Tanjore City Branch. He has released the hard copy of State Anesthesiologist Directory. He has organized the state level conference at Tanjavur and member of IJ Editor Board too. He has 6 oration and more than 750 lectures delivered across the country weekly. And there is, sir, has started the weekly anesthesiology academic webinar every Wednesday under the caption Puttukotai Buddhan, and 73 webinars already has been done. So welcome, sir, by the Society of Anesthesiology Maharashtra State. We again congratulate you. Thank you very much. Now it's time to felicitate our honorary secretary, sir, Dr. Rajiv Gupta, sir. Congratulations, sir. It's my honor to introduce on the day of his birthday. Today is sir's birthday, and happy birthday to you, sir. Next slide, please. So he has done MD Anesthesia and FIPM. He is a senior consultant and head of the Department of Anesthesiology and Pain Medicine, Maharaja Agrasen Hospital, Punjabi Bagh, Delhi. He is an honorary secretary of ISA National 25 to 28. He is a past DC member ISA National and he has been faculty at many international and national conferences. He has special interest in difficult airway, pain medicine and medical legal ethics. Thank you, sir, for joining us today. So now it's time to felicitate our honorary treasurer, Dr. Sunil Kumar Sethi, sir. I request Dr. Sachin Tendulkar to
Sorry for
kindly.
interrupting, Sheetal ma'am. Very sorry for interrupting. Sir, if sir is there, Gupta sir, can you
Sir, join नाही
address?
झाले.
Sir, he's
नाही
joining
झाले?
shortly. He actually was busy with some work. He's joining shortly. We can
हां,
ask
वेळ
him
आहे
to
सर
address
त्यांना
Okay.
later.
join.
Okay, sir. Then continue.
I request Dr. Sachin Tendulkar to kindly introduce our honorary treasurer ISA National, Dr. Sunil Kumar Sethi.
I welcome Dr. Sunil Sethi sir on the platform of SAMS. We welcome you all and congratulations to your 10 years. And your sir is a senior consultant anesthesiologist, Greek Hospital, Karnal at Haryana. Sir was a past GC member of ISA National 2021-24. Sir was past president of ISA Haryana and past secretary of ISA Haryana also. Sir did GC coordinator for ISA PPF between 2021 to 2024. Sir got proficiency award ISA National at 2021. Sir, congratulations and best luck for your tenure, sir.
Thank you, Dr. Sachin. Now it's time to felicitate our editor-in-chief IJA, Dr. Madhuri Kurdi ma'am. Now I request Shilpa Tivaskar to proceed.
Welcome, madam, and congratulations.
Thank you. Thank you so much.
Welcome, Dr. Madhuri Kurdi, madam, and congratulations. You are being aptly chosen as the editor of ISA National. Madam is MBBS MD professor at Department of Anesthesiology, Karnataka Medical College and Research Institute, Hubli, Karnataka. Madam is postgraduate teacher since 28 years and a PG examiner. Madam is at present editor-in-chief, Indian Journal of Anesthesia from 2025 to 2028, associate editor of JOACP and associate editor of Practical Evidence in Anesthesia Knowledge. Madam is also associate editor of Peak, associate editor of Vapor, the official newsletter of ISA National, and Madam is also on advanced course of medical education board for 1 year. Awards to Madam's credit. Madam has ISA IJA Best Peer Reviewer Award for IJA from 2016 to 2017. Madam has ISA National Proficiency Award to her credit in 2021. Madam has ISA President's Appreciation National Award in 2023. Madam has ISA Karnataka Eminent Anesthesia Teacher Award. Madam is awarded in 2024 with ISA Bhopal National Award for Academic Excellence. We welcome you, madam, and it's a great honor to host you.
Thank you very much. Thank you.
Thank you.
Thank you, Dr. Shilpa. Now it's time to honor Dr. Parul Jita, GC member national. I request Dr. Avinash Bhosle sir to kindly introduce. Hello.
Hello. Hello. It's my
hello,
pleasure
sir.
to introduce Dr. Parul Jindal ma'am. She is MBBS and MD Anesthesia and at present Professor, National GC member, RSAP, Department of Anesthesiology, HIMS, SRHU, Dehradun. Major achievement, difficult airway, pediatric anesthesia, PG teaching, CLS, BLS and ACLS. She is instructor. She is president of ISA Uttarakhand. She was president of ISA Uttarakhand state in 2022-24. Past president of DSA 21-22. Vice president, then organizing secretary of UA ISACON, then Uttarakhand ISACON 2024, ISA sponsored CME 2022, and then chairperson of many conferences. She was awarded as a ISA President Appreciation Award in year 2024, second prize for Rising COLS Awareness. Research paper won the prestigious Dr. Lalit Mehndira Award, won ISA Proficiency Award, Dr. B.C. Roy, and IMA Dehradun Appreciation Award. She won Diligent Award of ISA National and uh, Award for Best Poster in 2021. IMA President Appreciation Award and recognized as a top 100 reviewer by IJL. And she had 70 publications and research projects with her. I congratulate Dr. Parul Jindal madam, and I wish him all the
Thank you so
best
much,
for
sir.
the
It's an honor to be here.
tenure. Yes, ma'am. Thank you.
Thank you, sir. Now it's time to felicitate our Dr. Manjusha Saha, GC Member National. So, congratulations, ma'am. Next slide, please. It's my honor to introduce. Slide clear नाही दिसतंय का, sir?
Yeah, I will read it. Because she is my classmate and I did
Okay.
not require any slide for her.
Okay,
So
okay.
I will read it. Dr. Manjusha Shah, I am very glad to introduce her. She is my batchmate for MBBS and MD also. We were together at Solapur. She is MD Anesthesia, a consultant anesthesiologist at Naval Maternity and Nursing Home at Solapur and Sion, Mumbai. She was GC member of ISA National. She is now GC member of ISA National 25 to 28. She was organizing chairman of ISA sponsored National CME in August 2014, organizing secretary of various CMEs and conferences, and also chairman of various public awareness committees. She was president of ISA and president of IMA and West Zone chairman. She had Tribal Grant Award at World Congress, then Special Achievement Award at Misakon Aurangabad, National Award Prize for Best Public Awareness, then IMA State Award, and ISA State Branch Award for Best Public Awareness. She had publication and research projects in Grand, that chapter on anesthesia for PIH anesthesia, सच्चाई और गलत महिमा and booklet in Marathi, भूलशास्त्र समज गैरसमज. I welcome Manjusha Shah ma'am, and I wish him all the best for her tenure for next year. Thank you very much for joining.
Thank you, Avinash.
Thank
Thank
you.
you so much. And thank you, Sams, for this felicitation. I'm really thankful to Sams for giving me this opportunity and really a great support from Maharashtra State. Thank you so much.
Thank you, sir. Congratulations to all of you and best of luck to all of you. Now I request our president, Dr. Avinash Bhosle, sir. Stop slide. Slide बंद कर. गणेश?
If Navin Malhotra sir is joined,
बघते मी, sir.
yes, please check. Before starting the lecture, we will have some address from Malhotra sir and Gupta sir.
त्यांना जॉईनिंगला प्रॉब्लेम येतोय थोडा.
Okay.
डायरेक्ट लिंक नाही आहे ना, तर त्यांना ते मी परत ट्राय कर. नाही, अजून जॉईन नाही झालेच.
Hello. Yes, Dr. Rajiv is there, I think.
राजू
Dr.
sir,
Rajiv is
Raju
there.
sir.
Hello.
Hello.
We need to call him. Actually, he's there. Actually, it is his birthday, so must be busy with some ceremonies. Let me again call him.
So,
Yes.
okay, then can we proceed for our today's webinar, sir, with your permission?
Yes, why not,
Sethi,
sir?
sir.
Why not? Sir, please. Don't call me sir. We are colleagues.
नहीं
Not
नहीं
Avinash. Yes.
Yes.
Please, sir.
Okay. Again, good evening on this Christmas Eve. Uh, ISA provides comprehensive guidelines for practicing anesthesiologists in India, focusing on the patient safety, professional conduct, and evidence-based care, covering areas like mandatory pre-anesthesia checkup. All members of ISA should ensure the successful implementation of these new guidelines, translating them from paper to practice. The induction of anesthesia may be the most distressing procedure a child experiences during the entire perioperative period. Calming a crying infant before anesthesia indeed challenging, as babies often react to unfamiliar surroundings and stranger. So, how to handle this? We will. So please connect with us for this webinar and learn from our eminent speaker about these two crucial topics. So please stay connected. I request Dr. Parul Jinda ma'am to start the to deliver the lecture.
Oh, Chino.
Dr. Sheetal, should I start?
Yes, ma'am. Please.
Yes. Thank you. Are my slides visible to everyone? Good evening. Am I audible and are my slides visible?
Yes, ma'am.
Yeah,
Yes,
you are
ma'am.
audible. And slides are visible. You have to just make it
Thank you
full
so
screen.
Ma'am, it is full screen.
Okay, it's not full screen for us.
Just please check, roll the, yes, it's
Yeah, now
full
it's good.
screen.
Yes.
Yeah.
It's visible, ma'am?
Yes.
Yes.
Thank you.
Yes.
Thank you so much. And thank you so much, Dr. Avinash, Dr. Shilpa, Dr. Sheetal, who have invited me here as a guest speaker. Thank you so much for the lovely felicitation. And I'm really grateful to each and every member of SAMS who has voted for me. You have treated me as your own and it has touched my heart. I hope I live up to your expectations. And whatever I can do little for you, please let me know. Please, how I can be useful to you. Please do share with me. So I'll start with my topic today, and this is very close to my heart. My topic is how to calm a crying child perioperatively. I'm Dr. Parul Jindal, and I'm working as a professor in the beautiful state of Uttarakhand in Dehradun. So memories of the childhood may include a trip to the zoo, a movie, carnival, a vacation with the family, but sometimes a visit to the hospital may be in the cards. The entry into the hospital with parents and guardian may itself lead to anxiety to the child because he's in an unfamiliar circumstances. Here, in the perioperative area, he may meet medical personnel who are in scrubs, who are in hats, who are in uniforms. The child may encounter a very different environment altogether. The medical personnel, they invade the child's privacy when they're conducting the health examination and other procedures. The child senses that the parents are also uncomfortable and anxious and stressed, and he's separated from the parents. In the OR, the environment is again very different. There is a lot of sound coming out from the alarms, the monitors, and there is a lights are very bright there. People are dressed in masks and gowns, and there may be restraining and application of monitors onto the child. The child may be induced with a face mask and may require restraining, which may lead to suffocation to the child. When the child gets up from the surgery, he may experience pain and discomfort even though the parents are around. After that, the child is discharged and he comes to a familiar environment, his home. But psychological, physiological, and maladaptive changes which may occur post-operatively. And this may lead to feelings like emergency delirium, increased analgesic requirement, negative operative behavior, sleep disturbances, separation anxiety, eating problems,
new onset of aneurysm, and aggression towards the authority. In a reviewed article which was written by they have examined the risk factors of perioperative anxiety in the child. They say younger children are more prone for anxiety. The children who are introvert, they are reserved, they do not open up easily, they are more prone. Patients who are coming with repeated surgeries, a child who is coming to an area where the language is not familiar. Anesthesia factors like can also lead to more preoperative anxiety. If it is a child, he does not have a sibling, or if he's living in a rural area, if the parents are very anxious or the parents are divorced, if the environment is very uncomfortable or the access of nurses is very hostile, the preoperative waiting area is more, then these children have more risk of developing preoperative anxiety. So how can we reduce this preoperative anxiety? First, your manner is a long way. Speak in a loud manner, clear manner, but do not be condescending. Do not give the impression to the child that feelings are irrelevant. Don't laugh or tease the child unless you know them well, and do not use a scientific child. So every child has a different way of dealing, and every age group has different medication techniques. Let's see, in an infant who's less than 6 months old, he readily gets the parental surrogates and is less likely to experience separation anxiety. Response to soothing, gentle rocking, and sleeping is also helpful in a smooth and a calm child. In children belonging to the age group of 1 to 3 years, the child might have previous negative hospital experience. He experiences separation anxiety, may be inhibited and dependent on the parent's temperament, might be not very helpful to us. Between the age group of 3 to 6, these children are more concerned about bodily mutilation or harm to their body. They have simple explanation of procedure. Usually, effect is very effective in reducing the anxiety, and here the play therapy plays a great role. In between the age of 7 to 12 years, they need more explanation and participation. They benefit from choosing an anesthesia face mask or being allowed to hold the mask during induction. Toy storybooks and books can also be very helpful for these kids. In adolescence, they have increased awareness of the body, independence, and their own privacy. So, involving the age group in the anesthetic plan gives them a sense of control and can reduce their anxiety. Now we have another group which is the combative, agitated, or uncooperative children. Here the orals are not accepted, IV is not established, so we can give ketamine in the dose of 4 to 5 milligram per kg IM, which provides sedation in 93 to 100% of combative children in 5 minutes, and recovery is about 45 minutes. This can be given in the ward where the staff is adequate. We have to ensure that there is airway equipments, oxygen and JR circuits, and the trolley is tipped at both the sides so that the child does not fall and is safe during transport to the OT. So before that, we have to have a psychological pre-medication, which is a non-pharmacological antidote to anxiety. So we have various methods, desensitization, where we give a step-to-step approach to coping with painful stimuli. It involves slowly introducing the procedures and tasks and effectively moving from simpler tasks to difficult tasks. The child is taught the deep breathing exercises. In small children, we can even have party blowers or blowing of bubbles. The child has a positive reinforcement by giving him rewards, positive statements, or rewards like small gifts like stickers and toys. Or he can have modeled coping behavior where he watches another child or adult going through the procedure and rehearses these behaviors. In narrative review, in a review, there were a lot of interventions which were examined in this education by using booklets, leaflets, information towards tablets and video, uh, or play methods like group methods, clown therapy, therapeutic, music, active and passive, where the child sings or is listening to the music, and integrated preparation programs. So all these interventions have shown to have positive effects in reducing the child preoperative anxiety. We may also use distraction techniques like coloring books, videos, websites, which have been developed for children of all the age ages to educate them about the appearance of the OT, the equipment to be used, and how children have to be anesthetized. We can give them earphones to cancel the noise, portable internet devices, smartphones, give them Play-Doh to play around with, table-based games, magic, clowns, and music. So what are the concerns during parental presence? We have children who have cognitively impaired or with cancer or with multiple surgeries. Here we allow the parents to be in the OR while the child is being in, but they have to understand that they may be asked to leave the OR as and when required. The problem with this is that it is a disruption of the OT routine. We need additional staff to escort parents, but the legal implication is that at times the parents may faint and sustain injury. So if we have to understand that parental presence is not a right, but it is a push parents. This is a beautiful chart which I always show in my slides. This contains all the drugs which are used for pharmacological sedation, with the doses and the route of administration and the time to be effective. If we have any postgraduates, they can keep a screenshot of this and they can just revise with this. With the help of this, I'll not go into much details. We have benzodiazepines like midazolam, lorazepam, and temazepam. We have alpha agonists like clonidine and dexmedetomidine, which can be given by intranasal and PR routes. The benefits are that it reduces the need of the rescue in anaesthesia. We have the NMDA and
Madam, can I
which
interrupt?
can be given by per oral.
Can I interrupt? The chart is not
Yes.
seen. Yeah, now it is seen. Yeah.
Okay.
Yeah, sorry, continue.
So, coming over to the oral midazolam can be given in dose of 5 to 0.75 milligram per kg, and maximum dose is up to 15 to 20 milligram. The onset of action is 20 to 30 minutes, and the remission is a paradoxical emergent delirium and negative post-operative behavioral changes. There are very beautiful syrups which we were using earlier, Finargan and Vilargan. Finargan is promethazine 12.5 gram to 25 milligram. And amipirazine, which is a phenothiazine, can be given in the dose of 1 to 2 milligram per kg, 60 to 90 minutes prior orally, and duration of action is 5 to 6 hours. A non-barbiturate which was used earlier was chloral hydrate, which could be given orally or rectally in the dose of 5 to 25 milligram per kg. The onset of sedation to 45 minutes. It has a slow onset and a long elimination half-life. The active metabolite has a longer half-life and prolonged sedation and respiratory depression. For introduction of IV cannulation, we can use Emla cream, where it is used on the extent right one before this intervention after doing an occlusive dressing. The other method is by lignocaine magnetophoresis, which uses impregnated electrodes, a current generator, and a return pad carry the ionized lignocaine through the stratum corneum. But it may cause stinging pain during the current application and potential currents from the electrodes. My favorite mode of induction is using intranasal, which is my first line. And in the parent's presence, in the pre-op air, the child is laid in the recumbent position. We take the drug, either dexmedetomidine 1 to 2 microgram per kg, ketamine 1 milligram per kg, midazolam 1 to 0.2 per kg in a 1 ml insulin syringe. The total dose is 0.8 ml. It is around 0.4 ml is instituted in either nostrils 30 minutes before intranasally. One of the devices which is using MAT, nasally, it has a 1 ml attached syringe to this conical tip. We make sure that the dose is at the tip of the syringe and there is not a bubble which is present between the syringe plunger and the dose that will clear dead space. You can atomize a patient
Sorry
in
for
any position.
interruption.
Yes.
Sorry for interruption. The
No,
slide, there is
madam.
a lag between what you are talking and
Yes.
the slide. There is a
The
lag. It's not
slides
moving
and
with what you are talking.
your lecture is not coinciding with
Now,
each other.
Parul, I will suggest you
what I
can
can
switch off your video so that the things can move properly.
Yes,
Yes.
this is the slide that you are talking about. And
are
also
you
there is a disturbances while you are
Maybe her
your
network
voice.
is weak, so you can switch
Yeah.
off your video, then continue.
uh,
Yes, now it is okay, madam. Fine, continue.
I'm not able to see the video now. Just can give me a second, please.
Dr. Sheetal.
This is
Once she
the
finishes, Dr. Rajiv Gupta
conversation,
is
right?
also joined. so he can speak.
Containing the drug. This is how to attach the two together, and this is the action, the spray that comes out of the patient end.
So with this, Matt, it is important that we minimize the volume, maximize the concentration of the drug which is to be given, maximize the total mucosal absorptive surface area. We atomize the drug rather than drip it to cover the broad surface area. We use both the nostrils to double the absorptive surface area, and we aim slightly up and outward to cover the turbinates and the olfactory mucosa. Beware if you have mucus, blood, or vasoconstrictors, which may reduce the absorption. And do not suction the nostrils or consider alternate drug delivery methods. This is midazolam nasal spray, which is available as 5 mg per ml. Now, in children with special needs, we have 3 groups of patients like the craniofacial anomalies like Down syndrome, collaboration difficulties like autism, and motor dysfunction like cerebral palsy. In these children, they are fearful and suspicious of strangers, and establishing a rapport is very difficult. The child may be aggressive and sedation and pain. So we have to take into account the age and temperament of the child and increase the drug requirement for sedation and anesthesia, and various hemodynamic factors have to be taken into consideration. Always watch for the signs which increase the stress in these children. What is his special interest for distraction? Is he familiar with his books, or he is very fond of a toy? That toy can be in his hand while you give him a drug. Use a quite assertive voice with a focus on distraction. Provide low sensory stimulation to these children. Do not start any stress triggering factor. Unrespect the patient's time to adapt. Use anger to communicate or raise your voice. Giving into emotions could be counterproductive in these patients. So once you've given a sedation to any child, look for any airway event, cardiovascular event, or GI events and take care of them. Now, another factor which is important is troposomia, which is a distorted perception of an odor. We ask the child what is his favorite flavor, and we apply it inside of the lip balm. So what we do is we ask the child what is his favorite flavor. He says it's mango. We apply strawberry lip balm on the face mask, and we tell the child that as he inhales, he will see a shift from strawberry to mango flavor. So the child is induced with this technique. Another technique is by Cox Hall. Here, when the child arrives in the OR, we allow as many monitors as the child is allowing us. We ask the child to pick up his scented balm, and then we ask him to color it inside the mask. And then, with the child seated in front of the anesthetist, his back facing the chest of the anesthetist, the face mask is slowly and gently brought to the nose and the mouth. While 70% nitrous oxide is given in oxygen, and the flow of the breathing circuit is 5 to 7 liters. You challenge the child to blow and balloon the balloon and take a deep breath. The APL valve is kept wide open so that the child does not feel claustrophobic. As the nitrous oxide concentration equilibrate to the end-tidal nitrous oxide, we increase the 8% sevoflurane in a single move and reduce the fresh gas flow to 2 to 3 liters per minute. So as soon as the child loses consciousness, you place them supine and they continue to breathe sevoflurane and nitrous oxide. During this time, we do not allow the surgeon to touch the patient or do any maneuver at this point. If the child becomes apneic during this period, we gently assist the ventilation. Once the IV access is established, we administer propofol and insert the LMA or endotracheal intubation after the muscle relaxation. The inhalation technique we all know are of 4 methods. It could be a single injection, incremental induction, priming of the drugs, priming of the circuit, and steel induction. The children who have a phobia for the mask, what we do is we hold the JR circuit, the connector between interlacing the fingers, with the elbow of the breathing circuit positioned between the fingers. The cup of the hand is beneath the child's chin, and gradually we bring them closer till they cover the child's mouth and deliver 8% sevoflurane into the fresh gas flow. Alternatively, we can rotate the mask 90 degrees and use the balloon of the cuff to occlude the nares as the anesthesia is induced. In the post-op period, the child should be allowed to sleep undisturbed. There should not be too many stressful interventions together. If the baby is stressed, stop and provide the timeout. Slow handle the patient and movement should be limited. Avoid temperature and postal stress. Minimize the light and protect the eyes from bright light. The sound range should be 40 to 45 decibels in the NICU. Post-operatively, the child responds to touch. You can give him a gentle massage with 2 fingers or a thumb. Music and sound can be given, which is recommended especially by mother. The mother can also provide kangaroo mother care. Vestibular movement, swaddling or bundling can be done. There's a non-nutritive suckling is allowed, and head and cold temperature changes can be given, or acupressure can be put. In the post-operative period for the older children, multimodal analgesia using a combination of opioids, NSAIDs as per age, and local anesthetic is superior to any modality alone. Parental presence and discomfort of dressings and drains have to be kept in mind. These children are very prone for emergence delirium, which is 3 to 8 times higher in children less than 5 years of age, and it is present in about 20 to 80% of all pediatric patients. So, short-acting volatile anesthetics like sevoflurane, they show a higher incidence of emergence delirium. Rapid emergence, young age, post-operative pain, surgical procedures such as oral, ophthalmic, and otorhinological procedures can be done. In the post-op period, monitor the patients with for emergence delirium using the scale. A score of more than 10 has 64% sensitivity and 86% specificity, and a score of more than 12 has 100% sensitivity. So to prevent emergence delirium, we can shift over to TIVA or use a single dose of propofol 1 milligram per kg, opioids, fentanyl in the dose of 2 microgram per kg, or L-fentanyl 10 microgram per kg. Remifentanil infusion can be given intraoperatively as 0.5 microgram per kg per minute. Dexmedetomidine can be given as 0.3 microgram per kg at the end of the surgery. Pre-medication with single dose intranasal ketamine can be given in the dose of 2 milligram per kg. IV ketamine can be given in the dose of 0.25 milligram per kg 10 minutes before the end of surgery. And magnesium sulfate 30 milligram per kg followed by 10 milligram per kg infusion can be given. So my take-home message for you will be, please allow parental presence, practice your techniques and analyze which works best in your scenarios. Be compassionate, don't rush, make the family comfortable. You are special because you are an anesthetist, and that too a pediatric anesthetist. So a child crying is a communication, it is not a manipulation. It is a swift, gentle response which communicates in return. And you have to say, I hear you, I'm here, and you can count on me. Thank you so much.
Thank you, ma'am.
Thank-
Welcome to Dr. Rajiv Gupta, sir, our Honorary Secretary National. Welcome, sir. I request sir to deliver his to address the gathering. Sir, happy birthday, sir, from all of us.
Happy birthday, sir.
Happy birthday.
Thank you very much, madam, for the excellent lecture. And we will have a discussion after Raju Gupta sir's address. Sir, please.
Good evening, esteemed members. My chairperson colleague, Dr. Sethi, and treasurer, ISA National, President Dr. Avinash Bhosle, President SAMS, Secretary SAMS, Dr. Sheetal, senior colleagues, and dear friends. This is something very good that SAMS is regularly organizing the webinars, and they are good in taking the leap ahead in their academic sessions. At the outset, I express my sincere gratitude to all the SAMS members for their invaluable support, trust, and confidence in electing me as a Secretary, ISA National. With deep value of this responsibility, I assure you that with full commitment, I'll be there whenever you have any problem or whenever you want to suggest anything and you want something from ISA National, that they should come forward, and they are always there. As Honorary Secretary, my vision is to strengthen the unity among the members and enhance the transparency so that, the members can directly contact me whenever they feel like for anything, they can contact me. And we would like to promote the academic growth and all-round growth through the sports activities, cultural activities, and so many activities we are doing at the national level. And I would like that these activities and programs should continue. And each one of you, if you can suggest something more about these programs, you are most welcome. So together and collectively, and with the collective efforts, I am confident that we can further advance the mission of ISA and serve our community with dedication and excellence. Thank you.
Thank you very much, sir, for your talk. I wish you happy birthday and wish you a very successful tenure ahead.
Thank you.
Thank you very much.
Yes.
Sir, so we will have a discussion. Can please put your in suggestions on this first lecture.
Yeah,
Sir,
I want to know.
I request both the
joined late.
chairperson to comment on this.
I joined late, but yes, I heard the lecture of Dr. Parul. It was excellent lecture, and actually, this is this is a perpetual problem with the children, particularly small children. You don't want to separate themselves from their parents while taking them to the operation theater. So the ideas Dr. Parul suggested, most of us are using them, and yes, they are very good, and they can be followed if we are not, if anyone who is not following that. So this is excellent lecture about that.
Thank you,
Thank you
sir.
very much.
Seti, sir.
Yes. Thank you, Dr. Parul, for a wonderful brief talk, although it is a very long topic. But personally, I feel these are my suggestions. First of all, you should, if you are handling a kid of whatever age, especially above 1 year, you should be carrying a smile, you should be well dressed, and you should go to their room before taking them for the surgery, because that creates a rapport. Then when I go to pediatric patients, I hand over my phone to them, say this cartoon, and simultaneously I take the history of from the parents. Then I ask the parents to change and accompany me. If the child is in lab, then okay, and if the patient is in the lap of the mother or father, they can be taken to the OT table. And there, as Dr. Parul said, we have induction techniques and sometimes ketamine, sometimes propofol, sometimes the other things. Definitely, Dr. Parul has covered everything. But my opinion is you should be smiling and you should be prepared with your emergency kit also. Even if you are giving ketamine, patients can have respiratory arrest and you can be in trouble. Even with small doses. This happened to me very long back. One orthopedician said, just give a few milligrams of ketamine, I will do bedside IND. I said, no, sir, I will take him to the OT, only then I will give. And same day, I just gave 10 milligrams of ketamine and the patient had respiratory arrest. I told him, see, this could have happened outside the OT and we would have been in trouble. So if you are handling patients, pediatric patients especially, you should be ready with your gadgets, keep a smile, and you should be clear about your planning of anesthesia. Because if you, like scented mask you are using, some toys you can use. These are my personal experiences which I've been using. So please carry scented mask because the patients sometimes are very reluctant to put the mask. That's all. Thank you very much.
Thank you, sir. The anxiety is not only among the children, but the anxiety among the anesthesiologists is also there. When we are handling the cases at the remote places and single-handed at as a private practitioner. So, what is your suggestion or advice to us who are doing the pediatric cases at remote places and as a private practitioner single-handed?
So from my set, my advice would be first to have all your equipments ready, to have all your monitors in place, to know your backup plans what you'll do in case if something fails, to have the confidence of your team. Do not do something which you're not sure of, which you have not practiced, what you have not planned before. So always have your plan A, B, C ready with the child. Be friendly with the child. Engage the parents. If there is any comorbidity, please explain to them comfortably in a very comprehensive manner. Be condescending to the. Do not be condescending with the child. Do not use a loud voice. Be gentle with the child and the parents. Also, do whatever you feel you can handle. Do not have too much on your plate which you will not be able to handle it out. So your demeanor has a lot of value when you're handling a pediatric patient.
Okay. Thank you, ma'am. What is
One last
the...
question can I ask, Avinash sir?
Can I
Yes,
submit?
sir. Yes, ma'am.
Yeah, so Parul
Yes,
ma'am, if I have to use midazolam spray, what is the dose that you recommend? Only midazolam spray, suppose I have to use. So how much is one spray, dose
Yeah.
per one spray, and how much I can go? Suppose there is a 10
Ma'am, yeah. So I'll take that question with you. Intranasal midazolam, as I've said, is in the dose of 0.5 milligram per kg. So what you can do is each
So
puff
suppose a
has
10
around
kg child is there, so I can give maximum 5 milligram.
5 milligram you can use, and one puff has around 5 milligram per ml.
One puff has
5 milligram.
5 milligram,
Once
but okay, fine.
I am more comfortable using the atomizer because the dose there is calculated. And the results which I've seen are much better with the atomizer. It is not easily available even on Amazon.
Actually, some company had come up with it 6 months back. I don't remember. Yeah.
Initially, I had given this as a thesis to two of my candidates. It was not available in India and we had to order it. But now it is available on Amazon also. And it's
So,
very accessible.
okay, and
Teleflex, no?
do you use your recipe which you said, midazolam,
ketamine
ketamine, and
dexmedetomidine.
dexmedetomidine? All
I
three
use
in a
ketamine.
syringe you take.
No, either we've done it in 3 ways. We gave one patient midazolam, we gave one ketamine midazolam, the other was ketamine dexmed. The combination of ketamine dexmed was a lovely combination. The results were much better than any other thing which we had given.
And how much time after intranasal spray do you wait?
Around 30 minutes. It takes 20 to 30 minutes.
Okay, fine. And the IV is already in place when you do that?
No, we take the IV after that. Once the child is sedated enough in the pre-induction area, we take him to the OT. We give him either a single shot of sevoflurane and we establish a cannula. In small children, we've been able to do it without even sevoflurane, but we take care that we are giving him 100% oxygen at that time.
Okay, most of our practitioners are in private nursing homes. So where we where the child is there in the ward and we go there to take the IV, or the child is brought in the pre-op area of the OT and the parent is along with them, with the child, and we take the IV first. Like, so there, what would you suggest? Use
Then I
an
would suggest
intranasal midazolam and
for taking
ketamine.
the passive solution, if you can use some emla cream, I think that will be a much better option. Or you can
So
give
IV
intranasal.
and then directly pre-medication in the IV.
Yes, you can do that.
Okay, thank
Because
you, ma'am.
Yes. Thank you.
So,
Thank you.
ma'am,
I know there will be...
I have one question. Can I
Yes,
ask?
yes, no, there will, I know there will be a lot of questions. So we will proceed to the next lecture and we will take all the question at the end.
Okay, sir.
Okay.
Yes,
Okay,
sir.
it's already 8. We have
8 o'clock, yes.
time.
8 o'clock.
Okay. I request Dr. Madhuri Kodi ma'am to continue with his lecture, her lecture.
Yes, sir. Thank you. I just share my screen.
Yes.
Is my screen seen?
Yes, ma'am.
Yes,
It is
yes.
visible.
Am I
Yes,
audible?
yes,
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 ma'am.
yes. You are visible, audible.
Okay. So, first of all, thank you very much, Maharashtra State ISA SAMS, for inviting me, felicitating me on this podium. महाराष्ट्र स्टेट मधल्या सगळ्या माझ्या मित्रमैत्रिणींना आणि शिक्षकांना, बिकॉज आय एम अ स्टुडंट ऑफ महाराष्ट्र स्टेट, बॉर्न अँड ब्रॉट अप इन महाराष्ट्र, अँड इट इज व्हेरी क्लोज टू माय हार्ट. सगळ्यांना मी खूप आभारी आहे.
धन्यवाद
आणि
मॅडम.
हो,
धन्यवाद.
थँक्यू. तर today's topic, my topic is anesthesia, from paper to practice. And I've been asked to speak on these anesthesia pre-operative investigation guidelines. I bring you warm greetings from my institute, Karnataka Medical College and Research Institute, Hubli. Now, first of all, why are these pre-operative investigations? Why at all they are needed? First of all, for planning, how to plan your anesthesia technique and the perioperative planning, risk stratification, so that you can stratify which risk category the patient belongs to. Then once you stratify the risk, you can optimize the patient. That means you have to correct whatever you suspect, whatever abnormalities are suspected. They may be suspected or unsuspected abnormalities. And then finally, the perioperative management. All this is going to help in the long run by improving the patient outcomes. Preoperative investigations can help one to detect abnormalities that are going to adversely affect the outcome of the surgery. Then to assess the current status of the disease in patients with known chronic medical conditions. For example, if you have a patient of chronic kidney disease, you have to do serum creatinine, potassium, bicarb levels. If you have a diabetic, then glycosylated hemoglobin to assess the long-term diabetic control, electrocardiogram in patients with heart disease, and so on. Then, by doing preoperative investigations, you can even detect undiagnosed disease processes, which can put the patient at increased risk of perioperative complications. And in our country, it is very common that most of the time the patient comes to you with undiagnosed comorbid conditions. And also, preoperative investigations, if done, they can help to establish baseline values for tests that will be used for monitoring the patient after surgery. You know the baseline value of the particular test. Now, what are the current problems with preoperative investigations, with the practice of preoperative investigations? What is the practice and is it correct? Now, if you see, the practice of preoperative investigations is not uniform throughout the globe, and neither is it uniform in our own country. It varies from state to state, city to city, hospital to hospital, and so on, and consultant to consultant. So there are socio-economic considerations, there are demographic considerations, as I said, and there are medico-legal considerations. There is no availability of guidelines on the time frame of the validity of previous investigation reports. For example, if you have done hemoglobin 3 months back, should you do it again? There is no guideline on this. And all of you will agree with me that the practice of ordering a battery of investigations has become more prevalent with the advent of auto-analyzers. So it is very easy to do the investigations and get the reports. So many investigations are ordered. And in some cases, the preoperative testing is not based on patient characteristics or clinical indications. In fact, the testing may be done based on the institutional policy or provider preference, or to provide medico-legal protection to the consultant. Many physicians, they think that if you forego a particular preoperative test, then they are going to get exposed to medico-legal risks, So they are scared of that and then they advise investigations. Now, the question is, do all the investigations that we do preoperatively, do they influence the perioperative management and outcome? Now, the investigations are done to detect undiagnosed disease processes, and if they are done in the absence of clear indications, it is going to increase the cost of for the patient. And we also should remember that the chances of potentially high false positive rates when the pretest probability of a specific condition is low. So there are high chances of false positive rates also when you order a test. Studies have shown that preoperative testing, in the absence of clear indication, leads to abnormal results in 30 to 40% of cases. And all medical testing, as I've already said, there is a high chance of false positive. And once it is false positive, this can lead to many difficulties for the testing physician and most important for the patient. And when the test is applied to an asymptomatic population, the rate of false positive test goes on automatically rising up. And once the test is positive, you subject the patient to further testing, and so on, and the patient lands in deep trouble. Now, the overtreatment of false positive results is likely to occur, and these results may have very little clinical significance, but the patient is treated for that, and this can lead to patient harm. And you will also agree with me that unnecessary preoperative testing increases pain and inconvenience for the patient, right? The patient has to run from here and go to the lab, get pricked and all, and he becomes very anxious. And this leads to harm and anxiety to the patient because he thinks okay, something is very wrong with me, and that is why I have to undergo all this further workup. And in about 60% of cases, abnormal results of pre-op laboratory testing are not noted or investigated. Even if the abnormal results are there, nobody goes and follows them up. So, what are we doing? This sets us thinking, are we doing the right thing? Now, there are many global guidelines, the National Institute for Health and Care Excellence guidelines, ASA guidelines, and many hospitals, they have their own guidelines for preoperative investigations, and many consultants, they follow their own guidelines. Each consultant has his own set of guidelines, though he may not publish them, but they know that for this, this is how I'm going to investigate the patient. So, considering all this confusing background, there was the need for Indian guidelines for preoperative investigations was very much felt. And that is how, and also, that there may be global guidelines, American guidelines, but after all, we are practicing in our own country. There is a problem of ethnicity. The guidelines which are applicable to Americans may not be applicable to Indians. So there is a problem of ethnicity. And that is why, considering all this, the ISA preoperative investigations guidelines were prepared. So they were prepared to promote a judicious ordering of preoperative investigations and to aid in better patient outcomes, as I've already told you. Now, what do the ISA preoperative investigations guidelines focus on? They focus on routine preoperative investigations in ASA physical status 1 and 2 patients scheduled for elective surgical procedures. And they also focus on validity in terms of time frames for previously performed investigations. Now, in these guidelines, they have classified the types and urgency of surgery as follows. Urgency of surgery is elective, semi-elective, emergency, and specialized surgery. Invasiveness, minor, intermediate, major, and complex. And other factors also they've taken into consideration, that is the patient's current physiological status, comorbidities or medications that the patient is on, age group, pediatric, adult, geriatric, and special population, that is the obstetric and obese patients, that is the bariatric patients. And this is in the guidelines, this table is shown where they have categorized commonly done surgeries. They fall under which category? So minor surgeries, it includes all the superficial debridement surgery, breast fibroadenoma, hemorrhoids, DNC, and K-wire insertion removal, cataract surgery, minor urological procedures. Intermediate is open inguinal hernia repair, laparoscopic hernia repair, appendectomy, cholecystectomy, laparoscopic, varicose veins, benign hysterectomy, and so on. And major includes modified radical mastectomy, flap reconstruction surgery, total thyroid excision, Wertheim hysterectomy, arthroscopic shoulder reconstruction, femur fracture fixation. These are some of the surgeries which have been, the categories have been already put for these surgeries. Now, just in brief, how they prepared these guidelines. They did a literature search for relevant full text articles in English language published between 1st Jan 2010 and 25th November 2021. They conducted a systematic review of randomized controlled trials, cohort studies, cross-sectional studies, and case control studies related to these preoperative investigations. Expert consensus was sought. An anonymous survey was conducted among the expert group using Google Form, and the three-step Delphi methodology was followed to arrive at a consensus on the recommendations. Now, in these guidelines, they have defined when you say routine preoperative investigations, what do they mean? They are defined as those which may influence the perioperative anesthetic management and outcome in patients scheduled for elective surgeries independent of the specific clinical condition. And they have given a word of caution regarding these guidelines, that these guidelines should not be substituted for good clinical judgment. Good clinical judgment means what? You have to take a detailed clinical history of the patient. Clinical evaluation is a must. You cannot skip on evaluation, and a detailed review of the medications that the patient is on is a must. You cannot skip all these things. And tests for viral markers, including coronavirus 2, are screening modalities are not included in these guidelines. And the attending anesthesiologist should review the reports of the investigations ordered by another anesthesiologist rationally before proceeding with anesthetic management, because many times the investigations are ordered by one anesthetist and some other anesthetist comes to anesthetize the patient. And already told, detailed history clinical evaluation has to precede preoperative investigations. Do not order preoperative investigations blindly for any patient. Now coming to what are the exact guidelines and recommendations. Regarding complete blood count, the question was, in ASA physical status 1 and 2 patients scheduled to undergo elective surgery, routine preoperative complete blood count testing, can it change the anesthetic management or patient outcomes after surgery? The recommendation 1 is that preoperative complete blood count testing is suggested for patients undergoing minor, intermediate, and major surgery. Next is coming to renal function test. In ASA physical status 1 and 2 patients scheduled to undergo elective surgery, will routine preoperative renal function testing change anesthetic management or the postoperative outcomes? Recommendation is, the first recommendation for this is that preoperative serum creatinine estimation is not suggested for patients undergoing minor surgery. And the recommendation 2B, that preoperative serum creatinine estimation is suggested for patients undergoing intermediate and major surgery. Coming to serum electrolytes. In ASA physical status 1 and 2 patients scheduled to undergo elective surgery, will routine preoperative serum electrolytes, that is sodium and potassium testing, change the anesthetic management or patient outcomes after surgery? The recommendation is that preoperative serum sodium and potassium estimation is not suggested for patients undergoing minor, intermediate, and major surgery. Now coming to liver function test. In ASA physical status 1 and 2 patients scheduled to undergo elective surgery, will routine preoperative liver function testing change the anesthetic management or patient outcomes? Recommendation 4A, preoperative liver function testing is not suggested for patients undergoing minor and intermediate surgery. And recommendation 4B, pre-op liver function testing is suggested for patients undergoing major surgery. Coming to the coagulation profile, the same thing. In ASA physical status 1 and 2 patients, routine preoperative coagulation profile, meaning prothrombin time, INR, activated partial thromboplastin time, Will doing this change the anesthetic management of patient outcomes? The recommendation is that preoperative coagulation profile testing is not suggested for patients undergoing minor, intermediate, and major surgery. Coming to the blood glucose level, all of us have this question for blood glucose level. So in ASA physical status 1 and 2 non-diabetic patients scheduled to undergo elective surgery, will routine pre-op blood glucose estimation change anything? The recommendation is that in non-diabetic patients, preoperative blood glucose estimation is not suggested when the patient is scheduled to undergo minor, intermediate, and major surgery. Coming to the electrocardiogram, the 12-lead ECG. ASA physical status 1 and 2 non-cardiac patients scheduled to undergo elective surgery, will routine pre-op 12-lead ECG change the anesthetic management? The recommendation is that in non-cardiac patients, preoperative 12-lead ECG is suggested at age 45 years and above in those scheduled to undergo minor and intermediate surgery. Recommendation 7B that this pre-op 12-lead ECG is suggested for all patients undergoing major surgery, not even considering the age. Chest X-ray. The recommendation is that pre-op chest X-ray testing is not suggested for patients undergoing minor surgery. Recommendation 8B, preoperative chest X-ray testing is suggested for patients aged 50 years and above undergoing intermediate and major surgery. Coming to the airway. Now, the airway has also been included in these investigations. And the recommendation is that routine preoperative ultrasonography of the assessment of the airway is not suggested for predicting difficult laryngoscopy. Now comes the last thing in the recommendations, the validity time for the previous investigations. What is the validity time for previous investigations in ASA physical status 1 and 2 patients scheduled to undergo elective surgery? So the recommendation tell me that the accepted validity time for a previously performed normal complete blood count, RFTs, LFTs, coagulation profile is suggested to be 2 months, provided the clinical condition of the patient has not changed in the intervening period. This is very important. And recommendation 10B is that the acceptable validity time for previously performed normal 12-lead ECG and chest X-ray is suggested to be 12 months, provided the clinical condition of the patient has not changed in the intervening period. So this is a summary of the ISA recommendations, which I have just told. And this is how they have, depending on the nature of the surgery, the invasiveness of the surgery, they have made this table, and age-wise also they have classified for ECG and for chest X-ray. And the validity time for previously done investigations is also mentioned. Now, this particular guidelines was published in the Indian Journal of Anaesthesia in the May 2022 issue, and it was followed by a very nice editorial which we had written. One nation, one roof, one set of preoperative investigations, the guidelines overcoming a diverse demography. So how true it is that for our country, which is having so many states and so many different type of hospital categories and clinical practice, we needed one guideline, one roof, under one roof the guidelines were published. So that was the editorial. And there it was mentioned that India is a country of diversity, diverse in almost everything, including healthcare practices. And everything is, though it is evidence-based, there are several gaps in the area of preoperative investigations which we need to work upon. And one of these is the issue of ordering preoperative investigations. And it was also mentioned there that we should all remember that it is just not like that if there is a guideline, it is not the, what you say in Marathi, I think, Deva Vakya. Like, you have to follow this. It is not like that. Guidelines are not the commandments or fixed rules that practitioners have to strictly follow under any circumstances. They are only meant to encourage and assess the clinical acumen of the physician. When you're confused, you can take help of the guidelines, but please never think that it is mandatory that you should follow these guidelines. Why? I'll come to that later. Can be said that the steps taken by the Indian Society of Anesthesiologists to formulate evidence-based practice guidelines for preoperative investigations are in the right direction, and they were very much needed for our country. Now, meticulous history taking, careful clinical examination, use of meds, we ask what is the exercise capacity of the patient, bedside PFTs, all these you must do, and these can never be substituted by any investigation or any guideline for that. And our goal should be to follow the published guidelines, reduce cancellations in surgery, and improve patient safety and perioperative patient outcomes. That should always be our goal. Now, there was a comment on these guidelines that were published in the later on one of the issues of Indian Journal of Anesthesia, where some of the authors had commented that, especially on recommendation 6, they were not happy. So they said that the recommendation 6 of these guidelines states that preoperative blood glucose estimation is not required in the ASA physical status 1 and 2 non-diabetic patients scheduled to undergo minor, intermediate or major surgery. But the authors of this comment, they said that as per the International Diabetes Federation, the prevalence of diabetes in adults in India is quite high, 9.6%. That is 1 in 11 adults has diabetes. And knowing that more than 50% of patients living with diabetes are undiagnosed. So our concern is the detection and diagnosis of diabetes during the preoperative evaluation is very, very important. And by this recommendation, are we going to be able to detect diabetes, which is so much rampant in our country? In our country, when you ask whether you have a history of diabetes, they will say, no, we don't have. So it is only during the preoperative checkup that many of them are detected as diabetes. So this comment was very important, like it was an eye-opener. And also in recommendation 8B, the preoperative chest X-ray testing is suggested for patients aged 50 years and above. But again, the authors, they said that the need for every healthy 50-year-old patient undergoing an intermediate or even major surgery for a preoperative chest X-ray testing without advanced COPD or other lung diseases, suspected pulmonary edema, pneumonia, or mediastinal masses. Is it correct? That needs to be further studied because chest X-ray is expensive. It exposes the patient to radiation and may not provide any useful prognostic information. Then there was another comment on these guidelines that the current guideline considers extensive literature, but the current guidelines, they are based on weak evidence, and therefore we need to have further studies conducted on this particular topic of preoperative investigations, and we need to, on the basis of these published studies, we need to make more robust recommendations or strong recommendations for preoperative investigations. So I would say that whatever guidelines have been made by the ISA, they are an attempt in the right direction to bring uniformity in our nation, but they are based on weak evidence. So what should we do? We need to build up better evidence, stronger evidence on this topic. And so all of us, whether it's consultants, teachers, or even postgraduate students, we need to conduct research on preoperative investigations, conduct studies on this topic, publish them, and once we get better studies, we can once more publish better guidelines. So I took inspiration from the guidelines, and I myself conducted a study in my institute on routine preoperative testing of serum electrolytes, blood urea, and serum creatinine in patients undergoing elective surgeries of minor and intermediate risk and its implications on anesthetic management. And this was published in the Journal of Anesthesiology Clinical Pharmacology. And what we found is that we found that there is substantial evidence indicating that routine pre-op assessment of blood urea, serum creatinine, and serum electrolytes may not be necessary for ASA physical status 1 and 2 patients undergoing elective minor and intermediate risk surgeries. So, to conclude, I would say that the current scientific literature is insufficient to create strong evidence-based guidelines. Better evidence-based criteria are needed to guide selective proper testing. Preoperative testing is currently being overused relative to the current ISA guidelines. And I think the further this I hope my lecture has set you thinking in the right direction and will motivate you to to gather more evidence. Thank you very much. Thank you once more, Sams, and all of you.
Thank you very much, ma'am. It was an excellent lecture. I request the today's chairperson to say a few words about these guidelines. What is your opinion?
Thank you, Dr.
Okay, sorry, Dr. Rajiv, sir.
For this brilliant explanation regarding preoperative investigations and guidelines. Yes, definitely guidelines are required so as to standardize the practice, because it also has a legal standing also, because many times if something goes wrong, court asks for the standard guidelines. What is the standard guideline and what is the standard practice in the anesthesia? So at the time, if we have our own guidelines, we can give references for that. But many a times we have seen that preoperative investigations, which are actually not required, as you said, they are done just to protect yourself legally. Because many times I've seen that serum sodium in patients, older patients, 115, 120, but patient is fully conscious and oriented. So now the thing is, if we see these investigations, which is below the limit, and patient is fully awake, fully oriented, then how to go about it? We keep on repeating the samples. We are giving 3% sodium also. Similarly, in the potassium, because these are the high risk things, high risk electrolytes. We need to be cautious while giving them, and additional investigation and additional monitoring is required for that. So I think it is on the consultant that if the things are going fine, because many times I have seen APTT is 54, 55, 56, but coagulation profile, rest of it is okay. Platelet is 3 lakhs, INR is 1.1 or 1.2. Now there is dilemma whether to go for a surgery or not. So many times there are fallacious results also, as you said. So this depends on the consultant who is seeing the patient, that whether we should go for the further investigation or we have to repeat it, and that is all. But yes, definitely legal standing is there for these guidelines, so we should follow them in letter and spirit.
Okay, thank you, sir. Dr. Gupta, sir.
Dr. Sunil Sethi, sir.
Sunil Sethi, sir.
Yeah, sorry. Actually, what I follow in my practice is the standard reference from textbook of Wiley, that there are clear-cut guidelines given over there, what investigation in what age group you have to follow. So that is a standard textbook which we can follow. Although Indian ISA guidelines have come, I think most important is history taking. And I have seen some patients during post-COVID, in post-COVID area, I had encountered one patient who was having lower heartbeat. And that was considered to be like cardiac involvement during Corona. But there was no evidence. But accidentally, we performed thyroid function in that case, and the TSH was in the range of 100. So you cannot take it because the patient was of moderate build. He was not any involved in any physical strenuous physical activity or like he was a 70-year male. So I thought we should do TSH. So sometimes you have to judge the things clinically. That is more important. That is more important. We have to correlate the things. But if the age is above 50, 55, or 60, and patient is sedentary, you need to go for the investigation. And sometimes the like yesterday's talk of Dr. Madhuri, on Monday, yes.
Monday.
There was yes.
Yeah,
There are
Monday.
some drugs that patient can conceal. So we have to be very cautious that I have seen so many drug addictions also, as told by Dr. Madhuri on Monday. So we have to be very cautious. 25-year female, you don't expect that she will be a alcoholic or whatever. So we need to do the investigations according, because these histories are concealed sometimes. So we have to be cautious nowadays with the medical legal system. Definitely, some tests are not very much required. But as listening to Dr. Madhuri on Monday, that has raised my concern for the investigation. Thank you very much for the comments. Before I close, I must thank Sam for to be here on this platform. To all the dignitaries of Maharashtra, seniors, colleagues, friends, thank you very much.
Thank you, sir. We don't have a screening for diabetes and cardiac cases. So that is the problem. Madam said that the ECG before 12 months is also acceptable. How it is possible? And my question is physician opinion, pediatric opinion, or cardiologist consultation is required?
So what they have mentioned in the guidelines is that even if the ECG is done 1 year back, the clinical condition of the patient should be same and there should not be any fresh complaints. Now, if the patient doesn't give the proper history, then again you are trapped over here.
Even, madam, we have seen the patient having angioplasty 6 months back. It is clear, or CT angio is normal, and the patient having
cannot really tell anything. With 12-lead ECG just cannot ensure that everything is normal in this patient, the cardiac condition. That is why, because we know that one investigation is not sufficient, so we go on advising so many investigations.
What about the
outcomes?
Yeah. What about the
questions? Yeah, sorry.
Pediatric or physician opinion?
So the guidelines have not mentioned anything regarding physician opinion, nothing they have mentioned. But I personally feel that yes, it has to be, physician opinion has to be done. Why should we take any risk on our own shoulders? Whenever it is possible, we must make it multidisciplinary and we must involve the physician for an opinion. Though the final decision can be taken by us, we must involve the physician for his or her opinion.
Yes,
Avinash sir, there are some questions in the chat box.
Yes.
For Madhuri madam, please guide about the preoperative investigations in pediatric age group.
Pediatric age group, the guidelines have not focused on that at all. They have not told, because I have told they are only in the adult age group they are focused on. They have
What would you do in your institute?
In my institute, we would go for basic investigations, and then depending upon what complaints the baby has, then only we'll go for further investigations.
Okay, Dr. Rajesh Rao says, what is the harm in investigating thoroughly? So many things are detected without the patient history, like diabetes, hypothyroid.
I agree with him totally. That is what I had told in my lecture also, that though these guidelines are there, we have to think twice about following them. See, what he told is correct. What Dr. Rajesh Rao said, that the because
Thyroid
diabetes
and
is
diabetes,
rampant in
yeah.
our country, and if we are not going to do a sugar level even in the pre-operative period, we are very likely to miss it. So it is
Yes.
a very good opportunity to at least do one testing for the patient and find out. It is for the good of the patient only. We must do it.
Regarding the liver function test, madam, SGOT, SGPT, one of our gynecologists does is routinely for intermediate surgery like lap hysterectomy. And accidentally, one patient was detected to have SGOT-PT in 400 and 500, and then we had to postpone the surgery. So, what is your take? Whether for intermediate surgeries, at least creatinine and liver function test, SGOT-PT should be done?
See, the guidelines say not necessary. But what I feel is to be on the safe side, if especially for intermediate surgery, as you are saying, why not do it? You're not going to, I mean, how much are you going to spend on that? You can't go ahead and do it.
For Parul madam, there was a question which madam has answered on chat box. What are the endpoints of volatile induction in pediatric patient?
Yeah, so the endpoints are the loss of eyelash reflex, the child becoming from hyperactive or excited stage to a calm and a moving with without any purpose, and vitals become more stable. If the child is hyperventilated or there is shortness of breath, the child is breathing adequately.
Sachin sir, you had some questions?
Madam, how much this intranasal midazolam is irritant?
Sir, it is irritant, and it is documented that it is irritant. The nasal sprays of midazolam are irritant. So you have
Deepak Ani madam has, yes, ma'am, please.
so you have other options. You can use a combination of ketamine and dexmed, or you can just give ketamine alone or dexmed alone.
Okay, thank you. As Deepak Ane ma'am has posted one message, we will have our problem will be solved with that. If in abroad patients are seen by GPs regularly who have electronic data of all patients. Here some patient even with documented MS say there is no problem with them. It is just an example. So patient are hiding their history. If these all this history and patient's data will be documented, electronic data will be available, then we will have a better option.
True. I agree fully with this because if you have electronic data, nowadays many physicians they keep electronic data ready in the hospital.
Yes.
Yes, then that definitely that will help us.
Madam, can I ask one question? This is
Yeah,
Dr.
sure.
Shweta.
Please.
Yeah. So I just wanted to know, we don't ask positively for some investigations like creatinine or electrolytes. But if surgeons by practice default they do it, and if you find some abnormality, then medico-legally where do we stand?
Ma'am, very well said. Very well. That's a very pertinent question which you have asked. In fact, most of the surgeons, I don't know, in many of the medical colleges,
Yeah.
the surgery PGs and all surgery allied PGs and all the surgery surgeons, they do all the investigations and keep fearing that the cases will be cancelled. So when
Exactly.
I mean, what answer are we going to give to this? And secondly, as you said, that if you don't do a particular investigation and the patient lands into trouble, then where do you stand? Is the court of law going to protect you for that? So I think here, ma'am, the role of the ISA guidelines comes into the picture. Here we have our big brother ISA with the guidelines stating that it's okay. I mean, this as per the guidelines, you need not do it. But still, there is one clause over there that these guidelines are based on weak evidence. So even if you don't do the investigation, you can always argue it out that it was weak evidence.
Okay, because many a times it's PT-INAT, which is the most common.
True,
Like
true.
it is just 1.4, do it again or postpone.
Yeah,
So these are
yeah.
very common things. Yeah.
True,
Thank
true.
you, madam. Thank you,
True,
madam.
true. Very much.
Yeah.
Yeah.
So, madam, it is very difficult for these guidelines to come from paper to practice. If there is a
To
weak
conclude.
evidence, yes.
So can I ask a question to Parul ma'am?
Yes, sir.
Parul ma'am,
Yes.
I'm asking regarding private practitioner forum point of view. You mentioned about midazolam spray and then desk kit. In your practice, as you are an institutional practitioner, so which method you like to share with you that this one is very best for private practitioner?
So I would love to use a
Hello?
combination of Dexmed and Ketamine.
Okay, ma'am.
If it is available to you, then please go for Dexmed and Ketamine. The nasal irritation is also not there, one. Second, it cancels out the negative effect of either of the drugs. So you have a very potent drug which is available to you. So, and the dose calculation is also very simple.
Okay. Thank you very much, ma'am. My
Okay, thank
second
you.
question towards Madhuri Kurdi, ma'am. As we're discussing about legality of the perioperative guidelines, likewise, we have released one PPF guidelines also regarding laparoscopic procedure should have ETCO2, difficult airways should have
Monitoring.
VLOPs, and can we say
Monitoring
there are also
guidelines.
weak evidences for that?
Yes, sir. Even for that, the evidence is weak.
So we can stand in court of law as a
Definitely.
practitioner in rural places that I don't have ETCO2 means someone is asking me that you don't have ETCO2 and you gave a laparoscopic case in this setup. Can I say this is weak evidences from
But for
PPF guidelines?
ETCO2, I would not say that the evidence is
Yes,
weak
yes.
for laparoscopy.
ETCO2 should be there.
Yes, yes.
Yes.
For ETCO2, definitely no, sir. For other things, yes.
For VLSCopy,
It is
you can
mandatory
say.
investigate.
It is mandatory.
Yes,
Not
it is mandatory, madam.
Sir, whatever
Yes.
they have told in the private practitioner guidelines, they have taken into consideration all these things that practitioners will be going to different kind of nursing homes, different kinds of setups.
Madam, I think in present
yeah.
scenario, nobody is. We have to tell them that these things are required, and
Yes.
this needs guts. And
Yes,
when I started practice, madam, we used to carry the boil separators even with us, portable. But within 6 months, I made it sure that everybody buys it because they are financially very comfortable, so they buy it. And you have to teach them that all of this thing will go in one go if something goes wrong. And
Yes.
you need to call their leaders and tell them that these are the practical things, and you can be in trouble sometimes if you get stuck up. So we have to tell them boldly.
That's very true, sir.
True.
Yes, I was carrying oxygen cylinder also.
So, so take home message from this discussion, I think for private practitioner forum that investigation point of view you can judge through clinically, but clinical point of view,
Monitoring
point
point
of
of
view, you have to must that ETCO2 and VLSCopy with you.
It is mandatory.
Yes,
Mandatory.
yes.
Okay,
It is
thank you.
mandatory.
Thank you.
Any more question from audience and delegates?
There is one more question for Madhuri madam. As madam told us that investigations 2 months are allowed, right? So Dr. Gauri wants to know PAC is allowed for what duration? If I have seen the patient today and that patient comes after 3 months for surgery, is it allowed or do I need to do a PAC again?
The guidelines don't mention anything about PAC. They are basically based on pre-operative investigations they have commented on. They have not mentioned anything about PAC.
What practices
Madam,
you follow, madam?
there is a one thing that immediate pre-operative evaluation should be there. Even there is a pack yesterday you have to see patient again before you start the giving anesthesia. Immediate pre-operative checkup should be there.
Definitely, if it may be the pre-anesthetic checkup is done any time, but the patient's physiology can change, and so many
Yes.
changes can occur even in a span of 2 to 3 hours. So,
So
on the
immediate
table, wherever, please assess and then only go about.
yes.
In
There is
COVID
one.
times, in US also, they sent email to the patients
Especially in
and
obstetrics
that
patient.
email should be filled by a patient 24 hours prior to the.
Especially in obstetric patient, the airway grading are changed
So
hours
there
to
is
hours.
24 hours is timeline from US point of view. These people accept 24 hours prior PAC of patient.
Okay.
Hello.
Yeah, that's good
Can
to
I
know, Dr. Sachin.
can I ask one question to Parul madam?
There is
Dr.
a
Yes,
Naresh Pali.
question, I think.
Yes.
yes, please.
I have been using Dexkit combination since last 10 to 12 years,
Yes, sir.
and mostly intravenously, right from neonate to morbidly old patients. So you recommend only for
Yes, sir.
intranasal use, or you recommend for intravenous use also?
Both, sir. Both. If you have an IV access in line, it's a very good combination to use.
It's very good, and it takes care of the airway and all. There are hardly any airway issues.
Requirement for other drugs
It's just
also.
like natural sleep.
Yes, sir.
We'll go to a last question here because it's time 8:47. Is spinal or epidural anesthesia is acceptable for laparoscopic surgery? Yes, Madhuri Kodi ma'am. This question is for
Spinal
you.
or epidural. This is not related
What
to
is your
investigations, but I think this is a burning question. No, this is a burning
guidelines?
question right now. It's not in the purview of my
Investigation.
lecture, but I know that it is a burning question in the mind of everybody. And all want to give spinal epidural for laparoscopy, but where is the evidence? So we have Dr. Naresh Paliwal here, I think, who can.
May I share my personal experience?
There are a lot of
Yes.
Even our
Yes, sir.
president
Yes,
sir
sir.
also gave, na?
Yeah, I have given spinal as well as GA in many cases, but in few cases I have tried spinal epidural, segmental spinal, and it is a wonderful technique. But I reserve it for the very difficult cases where the patient is either COPD or cannot tolerate GA or spinal. In that cases, I am giving segmental spinal. Very few cases. But it is very effective. In the segmental spinal, they don't even have hypotension for cholecystectomy. And it is a wonderful experience for me. Anybody who wants to ask anything can personal message me.
No, sir. Yeah, the question I am also using, I am giving spinal anesthesia since 2003 for laparoscopy surgery. It's almost 23 years, and there is no complication in these
Avinash sir,
23 years.
are you
But
using lumbar spinal or
yes,
segmental spinal?
lumbar spinal.
Sir, lumbar spinal, we have given to so many cases, but the issue is of shoulder pain. But that
So
is gone in the
I give
segmental spinal.
diaphragmatic installation 20 cc.
So that is also not required in the segmental spinal. The patient shifts himself to the stretcher after the surgery. There is
Yes, sir.
no hindrance in the movement.
No,
Both
the risk of injury to spinal cord, that
Sir,
anxiety is always
if
there
you
while
listen
doing
to
CPD.
Dr. Naresh Paliwal sir and his talk and thoracic spinal, we have those people who are using it. It is very safe, but the only thing is you have to be confident in thoracic spinal.
Yes, yes. Even
And it is once you start. I started in Ayushman patients, those who were initially very safe on both sides. I tried in those patients. Then I gave in the high risk patients.
yes, yes. Even I'm using since last 23 years. So many cases. Every laparoscopy surgery in Satara at that time was done by me. That time in 2003. But even after this, my advice is, if there is a availability of the all things, that is workstation, you are working at the corporate or institute, you should go for GA. That is my suggestion. But here question is different. Is it legal? Or
Can I say something?
the question is spinal anesthesia epidural or segmental spinal. What is the legal implication if something goes wrong?
Can I add?
Yes, sir. Yes.
We are
Please.
doing almost every month a masterclass and a workshop. So we always recommend that it should be used in cases where it is most indicated. And those who are well
Yes.
conversant with this technique, they can use it regularly. I am doing it regularly. Almost my 50% cases
Yes.
are in segmental. Yesterday only I did a case of MRM which was rejected by all. She had only one lung and it was for MRM, 89 years old. And she moved from table to stretcher and took oral immediately. It was in segmental spinal. So in such cases, you can always justify you're doing it in segmental spinal. But in other cases, you may not be able to justify this. So we always recommend that till the time it comes in the standard textbooks, you just
Yes.
use it in cases where it is most indicated.
Yes.
You can
He
always
is the gold
justify.
standard.
There
At
are
least
many
5.
many publications and many these things nowadays. So it can be justified where it is most indicated. And it's a very wonderful technique. If you go through it.
Yes. Yes. Thank you. Thank you very much.
Thank you.
It's
There is one more
we'll,
question for Dr. Parul, madam, sir, by Deepa Kani, madam. What about melatonin use in pediatrics?
Melatonin
Yes.
can be used. I've written it to her in the chat box. It can be given per orally in the dose of 0.25 to 0.5 milligram per kg prior to 60 minutes prior to induction. And it actually is as a natural sleep inducer, and it reduces the emergency agitation also.
Can I add to this?
Yes, ma'am.
Yeah, I have did many studies on melatonin and published them also. And my personal opinion, it does cause sedation. It does, but nothing parallel to what is produced by midazolam or dexmedetomidine, ketamine, nothing parallel to that. In fact, the first study on melatonin in India I had published first in adults, followed by in children. But my practical experience was that the sedation is definitely not equal to what you get with other agents. So I feel it is more of a research drug or a study drug. This is my personal opinion.
So thank you, madam. We'll go. We'll now end the this topic and webinar. I request Dr. Sheetal to present the vote of thanks. Hello, Sheetal. Hello. Sheetal, please unmute yourself. Hello.
Dr. Sheetal, are you saying something?
No.
We are not able to hear.
Network issue is there.
So
I think
yes,
we should
Sachin?
Ganesh, can
Shilpa,
you share slides, last 2 slides?
Sheetal, please. Yes. Shilpa, can you present the vote of thanks, or I will continue? Should I continue?
Yeah, continue, sir.
So,
Okay. Yes, Sachin.
We should thank to Dr. Sanjay Patange sir, our
renowned
surgeon from Nanded. He is today's webinar MMC observer.
That is the last
last
slide
document.
in our
Yes. Now this one is. Yes, sir.
Yes, Ganesh. So, I thanks to all the office bearers of ISA National mm, for this attending this webinar and accepting our invitation. I thanks Dr. Parul Jindal ma'am and Dr. Kudi ma'am, Madhuri Kudi ma'am for delivering an excellent lecture. And I also, yes, Sheetal, I also thanks.
Sir, I have joined.
Yes, please. Yes.
So it's my honor to propose the customary vote of thanks. I express my gratitude to all the national office bearer, including our respected Dr. Naveen Malhotra sir and his team for the year 25-26 for for accepting our invitation for felicitation. I express my gratitude towards our faculty today, Dr. Madhuri Kurdi madam and Dr. Parul Jindal madam for sharing their vast experience in respective topic. I also sincerely thanks to Dr. Rajiv Gupta sir and Dr. Sunil Kumar Sethi sir for giving their valuable inputs as a chairperson. Thanks to all past office bearers of SAMS, advisory members, all GC members, President, Secretary, and special thanks to Dr. Zakir Patel, Organizing Secretary from the Nanded and Nanded Association, Society of Association of Nanded Anaesthesia for the MMC credit hours giving to the SAMS for today's webinar. So thank you very much and happy Christmas to all of you.
Thank you very much, Dr. Patange sir, MMC observer, for attending this webinar. And I request all the delegates who had registered for the MMC point, please fill up the feedback form which will be sent in next few days. So thank you very much. Happy Christmas to all. Good night.
Good night.
Merry Christmas to all. Yes, thank you. Good night.
Thank you.
Thank you, everybody. Thank you, Avinash.
Thank you, Madhuri
Thank
madam.
you.
Thank you, Parul madam.
Thank you. Thank you very much.
Thank you.
ISA
Thank
National
you,
ma'am.
ma'am. Thank you. Thank you.
Thank you, everyone.
Thank you.
हॅलो मॅडम मीटिंग एंड करतोय
रेकॉर्डिंग
yes.
एंड मीटिंग
Yes.
एंड करते का मला वाटलं रेकॉर्ड
रेकॉर्डिंग तर बंद केलं त्यांनी.
रेकॉर्डिंग बंद कर मीटिंग
पॉज केलं त्यांनी, पॉज केलं तेव्हाच.
ठीक सगळ्यांना हॅपी क्रिसमस.
तुम्हाला मॅडम सगळ्यांनाच.
ठीक आहे.
Thank you very much.